We would like to start the next session on port-site metastasis and port-site excision. To chair this session, I would like to invite Dr. Dinesh Yadav, Senior Professor in Department of Surgical Oncology, Mahatma Gandhi Medical College. Sir, please kindly.
Good afternoon. For this topic, I invite Dr. Vikram Chaudhari, sir.
Thank you, Professor Kapoor, for this opportunity. And the topic given to me was port-site metastasis and role of port-site excision. There is very little prospective evidence. There are hardly 20 studies on this topic in the literature. Many of the studies which quote the incidence are not dedicated to this topic.
Until then, I would request Sumita Jain ma'am, HOD Department of General Surgery, SMS Hospitals, to kindly, if she could just chair over this session.
So the topic given to me was port-site metastasis and the role of port-site excision in gallbladder cancer, particularly the incidental gallbladder cancer. So the port-site metastasis happens because of the tumor cell implantation at the trocar site, and these patients tend to form a palpable mass in the anteroabdominal wall at or near the site of the prior port or incision, and it can be a source of significant intractable symptoms in quite a few patients when they develop. In few patients they can be small masses which can cause pain, and in some patients it can even form a large fungating mass where if you offer surgery it can even require a major flap like this. They can be divided into either isolated or disseminated port-site metastasis. Most, in fact 80 to 90% of the port-site metastases are associated with disseminated peritoneal disease and systemic disease. They can occur either at extraction site or non-extraction site, and 80 to 90% of the port-site metastases occur at the specimen extraction site. The actual incidence of port-site metastasis is debatable. Most of the literature quotes the incidence between 2 to 14%. However, I came across a systematic review from a Canadian study where they reviewed the 20th century studies for around 15 years and the 21st century 12-year studies, that the 21st century incidence is around 10%. Previously, it was reported in around 18%. So somewhat the incidence is reducing, and the literature is clearly showing that trend that the incidence of port-site mets has gone down in last 2 decades. Gallbladder cancer is notorious to develop port-site metastasis. As compared to other GI malignancies, the incidence of port-site metastasis is higher with gallbladder cancer. In few patients with incidental gallbladder cancer, the primary is usually missed. So in cases of missed gallbladder cancer, port-site mets can present after a long period of time with a long DFI. And port-site mets occurrence after a lap cholecystectomy is slightly higher as compared to open cholecystectomy in the literature. So that's the introduction of this topic. It's a rapid process. It frequently diagnosed 1 to 6 months after index cholecystectomy. Most patients with port-site mets die of the disease recurrence and frequently present with associated peritoneal and systemic metastatic disease. So there are possible mechanisms which have been hypothesized and which have been studied in the literature. The mechanisms are either procedure related, which are related. The etiology can be pneumoperitoneal related, and finally it can be patient related factors. So the procedure related factors mainly deal with an improper tumor handling or tissue handling, the bile leak during the surgery, and the specimen extraction without a specimen bag. The pneumoperitoneum is known to cause a chimney effect. Sudden evacuation of air causes the chimney effect, and it is supposed to cause the implantation of the tumor cells into the port sites and resultant tumor metastasis in the port site. And the aerosolization of the tumor cells is also hypothesized to cause the port site metastasis. The patient related factors is the surgery related inflammatory response, decreased cellular immunity, blood osmosis, and the possible aggressive nature of the tumor and the hematogenous spread are the possible mechanisms which are patient related. So it is a multifactorial mechanism. It is difficult to know in a particular patient what exactly has resulted in port site metastasis, and therefore sheerly targeting the port site and excising them prophylactically may not be a good idea. However, there can be some strategies which you can do during surgery. So primary is to avoid the bile spill. The careful and delicate specimen handling, maintaining the oncological planes, use of extraction bags as a protocol, incision protection if you are extracting the specimen, and routine examination of the specimen after extraction and frozen section analysis in case of a doubt are few of the things which you can do to reduce the port site incidence of port site metastasis. Now coming to the role of prophylactic port site excision, the initial study was from I think MSKCC group, which suggested that the port site excision during completion extended cholecystectomy for incidental gallbladder cancer is not recommended. It's not a standard recommendation. It does not reduce the recurrence and with rising evidence suggesting its futility, the practice of routine prophylactic port site excision philosophical thing whether it is a systemic or a local disease. So if there is an absence of coexistent metastatic disease at any other site, and if there is no clarity whether you can consider a delayed metachronous port site metastasis site as a port site met. This study I think is from the AIMS group. It is a very interesting study. It points towards the fact that the isolated port site metastasis probably may be a different entity, and it may be in few patients represents a local recurrence rather than a systemic metastatic disease, because isolated port site metastasis in that study particularly, they seem to have a high level. The time to disease progression after intervention in these patients was higher as compared to the patients who had a diffuse metastatic disease. The mean survival in this subgroup is higher as compared to other patients, and the isolated peritoneal metastasis patients represent probably from the port site mets presenting as per systematic recurrence. So in the isolated port site metastasis subgroup, in few patients you probably can treat and consider them with curative intent and consider them as local recurrence is what the literature is suggesting. Dr. Shraddha, isolated port site metastasis at TMH. There were total 13 patients, all had undergone laparoscopic cholecystectomy. Interestingly, none of the previous centers had administered any systemic therapy in them. These patients were administered systemic therapy. 11 of these patients were operable. 2 of these patients received neoadjuvant radiation as the response to chemotherapy was not great. And you can see that after curative intent resection, the median follow-up of 2 years in these patients, the overall survival was around 3 years, and disease-free survival was around 20. How to approach the patients with isolated port site metastasis? So it is important to decide the intent we are starting the treatment, and therefore FDG PET and the staging laparoscopy are the two modalities which probably need to be utilized in subgroup, because this is the group where 80 to 90% patients are likely to have peritoneal disease or metastatic disease. Dr. Shraddha and Dr. Goel published this paper, studied the patients with oligometastatic disease who were treated with curative surgery, and in this subgroup you can see that the port site metastasis is the subgroup which has the highest survival of around 23 months as compared to all other sites of oligometastatic disease. So this is a subgroup where if you have a patient who doesn't have a metastatic disease at other site, it should be treated with curative intent and aggressively. To conclude, routine prophylactic port site excision should not be performed. It does not reduce the recurrence rates and has no survival advantage. The literature is unclear whether isolated port site metastasis represents a local recurrence or metastatic disease. Isolated port site metastasis patients with metachronous presentation may represent a different biology. Patients with isolated PSM should be treated with systemic therapy with neoadjuvant intent, and patients demonstrating disease response or stability should be operated for port site excision. Thank you.
Thank you, Vikram. Just one question. Is there any study like correlating it with the T stage? Like in which T stage port site metastasis is more like?
So frankly, I reviewed the literature to write the review, which Professor Kapoor had asked me. There is no specific study which looks at a T stage and correlation of development of port site metastasis. I at least have not come forward. If
figure of 7% for open. How many have you seen?
Very few. So, in the study which in which Dr. Shraddha and Dr. Goel had published, 13 like in those all 13 patients were after lab coli, and in our OPDs most of the patients have incidental GBC history, and
The ones I've seen are lab converted.
yes, so most of them are.
So you take it as oligometastasis or you take it as locally advanced gallbladder cancer?
So that's what I said, that it is unclear. So if the patient is coming back after a long DFI with a solitary lesion or a solitary port site met, and if there is no metastatic disease elsewhere, whether to consider it as a local recurrence or a systemic metastatic disease is are not clear. But because there is no other site of metastasis, most of these patients can be treated with curative intent is what I was trying to suggest. And that's what the literature is also suggesting.
Suggesting neoadjuvant for that and then resection. Why not resect and then adjuvant?
So you want to know how they are going to behave. Another argument is if you many of these patients have large tumors. If you can achieve certain tumor volume response in them, the size of the defect, managing them, knowing the disease biology, everything makes a difference. Otherwise, thank you.
Next speaker is Dr. V.G. Shelat from Singapore. Is it online or?
Good afternoon, everyone. I think I have not much to add since the topic has not much scientific data within the literature itself. But I might just enrich a little bit of what has been spoken on the theme. I think when we will eventually publish this as a consensus document rather than a guideline, maybe we should borrow some ideas from our upper GI, lower GI, and the Urogyne colleagues, because port site metastasis is a problem for everybody, not only for HPB surgeons. And there is a fair bit of literature, though it's not belonging to the HPB domain, but there's a fair bit of literature surrounding the theme itself. So that's one aspect. I think two decades ago, it was already published and reported widely that since Lep coli can lead to port site mets, that's why all CAGB or suspected CAGB should be operated by an open procedure. And I think we have moved on from that philosophical era, and I would not say that we should always do an open coli for a suspected or a confirmed CAGB case. Definitely laparoscopic or even robotic minimal access has a role. So my talk will partly overlap with what has been said, but I'll just share some ideas and comments, which is what I've been asked by Prof. Kapoor and team. So first of all, in our consensus, we need to be very clear what is the definition of port site mets. And there has been substantial literature defining what it means, but if you dig down deep, there are certain literature reports showing different pathology already. As for example, this case here. So primary should match with the port site, and that should be the sacrosanct definition of port site. Second would be drain site. There are some reports on drain site, and they drain, and these are only sporadic reports, and drain could be inserted as a part of lab procedure, could be through the 5mm port, could be put ad hoc through a separate stab incision. And when we put our consensus, we probably ought to give some clarity to this drain site met saga. And I would agree that we should probably categorize port site into an isolated port site where there is no evidence of disease elsewhere except the port, and patients where there is evidence of disease elsewhere in the body like liver, lung, peritoneum, etc. So moving on with the definition and clarity, then we need to understand why these port site mets happen, and I think the earlier speaker has already commented. But we need to know that there are certain factors which are non-modifiable. For example, though there is no much strong evidence of T1, 2, 3, 4 in gallbladder, there is a substantial data from Urogyne malignancy that advanced tumor stage is one of the predictor of port site mets, whether that's related to stage or whether that's related to difficult tumor handling and thereby mechanical spread being more likely, or that's because of tumor rupture or because of just non-gentle tissue handling by virtue of sheer size. We don't know. But definitely there are certain factors which will be non-modifiable factors, and those factors which are modifiable, I think our consensus probably ought to shed light on that, and in view of lack of evidence, we probably can take some brave steps to give some logical proposals for reducing the burden on port site mets or prevention. For example, there is substantial data of pneumoperitoneum, the higher intra-abdominal pressures, the prolonged time of the surgery, and that could lead to dissemination. So we could give some guidance on the pneumoperitoneal pressures. Say, for example, I think spillage has been talked and discussed widely, and most of us agree that spillage is not an act of convenience or an act of choice. It just happens because of technical difficulty. A lot of people have spoken about endo bags, but the problem is after difficult operation, we tend to irrigate the peritoneal cavity, and this irrigation fluid bathes the external part of the endo bag. So endo bag would not prevent the port side problems because the outer side of the endo bag is now being exposed to the intraperitoneal content where potential tumor seeding has already happened during the procedure, and irrigation might even make it worse. And that's why endo bag is not really an Achilles heel to prevent the port side mets, though it may serve to reduce a little bit. There's minimal talk about port side air leaks. We generally don't document the use of CO2 during the lap chole. We document uptime, we document blood loss, we document many other things which we believe are important, but we hardly document how much carbon dioxide is being used, and that is directly proportionate to the air leaks, changes of instrumentation, etc., and a little bit of it is related to technique. And that could actually aid in terms of identifying the risk factor for port side, which is possibly mentioned here. The immune and inflammatory response is, the literature is debated and both sides have been reported. Some people say that immune reduction or immune suppression leads to port side mets. There is some literature which suggests that immune enhancement or normal immune competency actually paradoxically serves inflammatory oncotoxins and thereby leads to mechanical mets to the port side. So this immune inflammation concept in the literature itself has some paradoxical things which probably we ought to discuss in our consensus statements. And I think we need to, once we know the identifiable risk factors, we probably also should talk a little bit about precautions and how this could be reduced or prevented. I think just saying gentle manipulation, avoiding perforation, which is all reported, or using bag is not sufficient because nobody does a hard manipulation, nobody does a deliberate perforation. So such loose statements in our consensus should be avoided because it doesn't serve any meaningful value for ground level implementation for people to change their practice or even the consensus to remain some credible piece of document to resort to. I think once we are clear how to prevent it, well, I've added some slides here which are mostly coming from non-gallbladder, from urogyne era. I've never irrigated anybody with 5-fluorouracil, but these things are reported in oncological literature to reduce the burden of potential port side, and we could consider giving a soft recommendations without much evidence or given, in our consensus. We can take a liberty to write such things with the intention for people to see if they want to adapt, of course, after informed consent of the patient. More importantly, I'm not here to guide the technique. I've done less than 5 port sites to answer some of the questions. I have seen less than 10 patients, and most of those things I have done is belonging to my senior consultants and professors who were in charge. So we have removed some port sites, and I've been always taught when you remove a port site, please go from skin down all the way, take an adequate margin. The previous incision must be completely excised. And it's definitely not considered a locally advanced disease, but it could be either a isolated mass, a part of systemic saga, which is unsure. I would probably say that literature has these various words. One is a tumorectomy, one is called hook wire localization, and again cherry picking or tumorectomy. And again, what's the margin, 2 cm, 1 cm? I would say oncological negative margin, at least for the sake of our consensus statement. When should we do? If there is a systemic disease, patient actually needs systemic therapy, and not to overtly promise long survival gains. Cautiously, discussion with the patient with potential survival gains has been shown by the Tata paper. With maybe the right approach that a multidisciplinary may encourage a resection would be we have to make it clear that patient must be in agreement that resection of port site is not the treatment itself as far as it's combined with the chemotherapy, either before or after, doesn't matter. So patient willingness to take the entire package of the treatment along with the port site excision, the willingness for taking some form of adjuvant or palliative intent chemotherapy would be my suggestion for the consensus document that, you know, patient can't just say, I'll take surgery, but I prefer not to take chemotherapy part of the treatment. Some patients may not have willingness to go for surgery for various reasons, and if they still have an isolated port site, we could actually offer some form of external beam radiation, or there are some data with brachytherapy with implanted seeds as well, and that probably could be discussed in our consensus statement as well. With regard to whether this is a systemic disease or this considered a solitary local recurrence, I think there is no data or there is no at least scientific proof I could dig out from the literature and say is anyone's guess. But I would say that we should probably consider it as a systemic disease, though we can.
Is selective which cases. Post-site excision should be included as part of the completion extended cholecystectomy for excidated gallbladder cancer. However, this is not practiced uniformly in the current literature. Hence, it can be performed selectively for that question, though extracting the gallbladder if performed during CEC for excidated gallbladder carcinoma. It is because the etiology for the occurrence of post-site metastasis is multifactorial, including direct contamination of the post site during extraction of gallbladder, tumor cell seedling due to pneumoperitoneum, gallbladder perforation, and bile spillage causing contamination of all ports. Hence, PSM can occur at the gallbladder extraction and non-extraction post sites. The extent of the post site excision has to be wide enough, 1 centimeter around the scar, as the ports are usually placed in an oblique fashion. Further, full thickness tissue from the skin down to the peritoneum should be excised. Another issue is delayed metachronous post-site metastasis after index cholecystectomy, where no reoperation was done. Is it a local or metastatic disease? In the absence of coexistent metastatic disease at other sites, there is no clarity on whether delayed metachronous PSM after index cholecystectomy should be considered a local or systemic metastatic recurrence. A proportion of such patients may have disease solely due to local seedling. However, it is difficult to identify these two groups separately. In that case, 18F FDG PET-CT plays a very important role in the diagnosis, staging, and management of these patients presenting with late post-site metastasis. Staging laparoscopy is a standard practice in gallbladder cancer. However, there is no recommendation on the role of staging laparoscopy in post-site metastasis to rule out coexistent peritoneal disease, as this clinical situation remains uncommon. Considering the higher incidence of associated peritoneal disease in post-site metastatic patients, staging laparoscopy is likely to have a higher yield and may facilitate better counseling of the patients about the treatment intent before initiating systemic therapy. What about the isolated post-site metastatic with no other disease on PET scan? What should we do? The literature is unclear whether isolated post-site metastasis represents a local recurrence or metastatic disease. After carefully excluding the presence of coexistent metastatic disease, these patients should be treated with chemotherapy with adjuvant intent. Patients demonstrating disease response or stability should be operated for post-site excision. Systemic therapy may provide an in vivo indicator of disease biology and help select patients in whom post-site excision may be performed later to provide possible survival advantage. This approach is likely to provide survival benefit in this select group of patients. Thank you very much.
So, thank you, Dr. Shelat. Thank you, Dr. Vikram Chaudhari, sir. And thank you, Dr. Myint. And, sir, any question?
evening. Myself T.D. Yadav from PGI. So two important things in our experience are I could not find in the presentation. One is duration between the gallbladder surgery and appearance of the port metastasis. And I think this is very important because we are thinking that is it like incidental gallbladder cancer. So if it is what we follow, if it is as Vikram said, we do PET scan, we do a staging lab, but it is also very important. After 2 years it is coming, within 1 year it is coming, or it is coming more than that. All type of spectrum patients are coming. So I think it's very important whether we treat them like remove the port metastasis after neoadjuvant, we regularly follow, and then are you going to do completion extended cholecystectomy at the same time if patient is coming early, or you are only removing the gallbladder port side metastasis, taking all the margins clear. I think I have seen 12 years after the gallbladder surgery, laparoscopic surgery, one gentleman from Punjab, but repeatedly incision was being done and his wound was being drained, and he went on increasing and it became 12 centimeter. We give chemotherapy as you said. So these are, I think, some issues which still have to be thought about. Thank you.
This is the only one study, that AIMS study, Chauhan et al., that showed that as the interval between the prime index surgery and the port side met increases, the survival is the better. So that is there in the literature, but that's the only study which actually focused on that part of analysis, that if the DFI is longer, those patients will do well. Agreed, yes,
So-
agree.
Yeah, I agree. I mean, once we have a port side met, even if the time of presentation is important, the later it presents means a better tumor biology per se. But it's still a metastatic disease. Just a question to all surgeons actually. We are talking about port side mets. I was just thinking, if we have an open cholecystectomy for a difficult gallbladder and we have to go in, do scar or just going through the same scar? No, I wanted to ask whether we go through the same. No, we have an open scar of a difficult gallbladder surgery, and we have to go. Now we have we have to do a revision. So do we excise the full scar, or we just go through the same scar? Yeah, incidental. Yeah.
And in laparoscopy, we are extracting this scar from the gallbladder that we extracted. If we are able to find from the primary surgeon from which port we are taking the gallbladder. And if that, then we are simply taking the port in most commonly. So we extract.
No, that's right. No, that's a thought which came to my mind. So
Only just a little bit of the scar just for the
The recurrence is happening arbitrarily after 6 months. So these are the different patients probably. In those patients, if